Hello everybody. Welcome to Number 1 Doctor channel. Today's video is about diseases of the breast, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel Number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about diseases of the breast. In all breast disease, cancer must be ruled out even if the presentation suggests benign disease. The only sure way to rule out cancer is to get tissue for the pathologist. Age correlates best with the odds for cancer, virtually unknown in the teens, rare in young women, quite possible by middle age, and very likely in the elderly. The much-quoted statement one of every 8 women in the United States will develop breast cancer is true only for those who have reached the age of 85. Women with family history are at risk from an earlier age. When breast cancer arises in young women, it tends to be very aggressive. Mammography is not a substitute for tissue diagnosis but an adjunct to physical examination. Breast masses that may be missed by palpation may be seen in X-rays, and vice versa. As a regular screening exam, mammography should be started at age 40 earlier if there is family history. Mammograms are not done before age 20. Breast is too dense or during lactation all you see is milk, but they can be done if needed during pregnancy. Mammographically or sonographically guided multiple core biopsies have become the most convenient, effective, and inexpensive way to biopsy breast masses, whether they are palpable or are discovered by screening mammogram. Women who inherit the BRCA gene need early and frequent screening, but it should be done with MRIs rather than mammograms, which are carcinogenic if repeated frequently. Furthermore, past the age of 30 they should consider prophylactic bilateral mastectomies if they have the BRCA2 mutation, and that plus oophorectomies if they have the BRCA1 mutation. Fibroadenomas are seen in young women late teens, early 20s as a firm, rubbery mass that moves easily with palpation. Either fine needle aspiration FNA or sonogram is sufficient to establish diagnosis. Removal is optional. Most women want them out, and we are happy to oblige. Cystic sarcoma phalloides is seen in the late 20s. They grow over many years, becoming very large, replacing and distorting the entire breast, yet not invading or becoming fixed. Most are benign, but they have potential to become outright malignant sarcomas. Core or incisional biopsy is needed. FNA is not sufficient, and removal is mandatory. Mammary dysplasia. Fibrocystic disease, cystic mastitis is seen in the 30s and 40s, goes away with menopause, with bilateral tenderness related to menstrual cycle worse in the last 2 weeks and multiple lumps that seem to come and go. They are cysts also following the menstrual cycle. If there is no dominant or persistent mass, mammogram is all that is needed, but if there is a persistent mass, presumably a cyst but potentially a tumor, further steps are required. Aspiration is done, not FNA, but aspiration with a bigger needle and syringe. If clear fluid is obtained and the mass goes away, that's it. If the mass persists or recurs after aspiration, formal biopsy is required. If bloody fluid is aspirated, it should be sent for cytology. Intraductal papilloma is seen in young women 20s to 40s with bloody nipple discharge. Mammogram is needed to identify other potential lesions, but it will not show the papilloma. They are tiny. Galactogram may be diagnostic and guides surgical resection. Breast abscess is seen only in lactating women. What appears to be a breast abscess at other times is cancer until proven otherwise. Incision and drainage is needed, but biopsy of the abscess wall should be part of the procedure. Breast cancer should be suspected in any woman with a palpable breast mass, and the index of suspicion goes up with the patient's age. Other strong indicators of cancer include ill-defined fixed mass, retraction of overlying skin, orange peel skin, recent retraction of the nipple, eczymatoid lesions of the areola, reddish orange peel skin over the mass, inflammatory cancer, and palpable axillary nodes. A history of trauma does not rule out cancer. Breast cancer during pregnancy is diagnosed exactly as if pregnancy did not exist and is treated the same way except for No radiotherapy or hormonal manipulations at any time during the pregnancy, and no chemotherapy during the first trimester. Termination of the pregnancy is not necessary. The radiological appearance of breast cancer is an irregular, speculated mass with asymmetric density, architectural distortion, or fine microcalcifications that were not there in the previous mammogram. Treatment of resectable breast cancer starts with either of two operations. Small lesions, located far away from the nipple and areola of a large breast, are removed within only a segment of the mammary gland. The operation is called lumpectomy, or segmental resection, and it must be followed by radiotherapy. Large tumors lying right under the nipple and areola, and occupying most of the small breast, require a simple total mastectomy and do not need subsequent radiation. If lymph nodes are not palpable in the axilla, either operation must include a sentinel node biopsy. If enlarged lymph nodes are palpable in the axilla, they are resected. Infiltrating ductal carcinoma is the standard form of breast cancer. Inflammatory cancer is the only variant with much worse prognosis and the need for pre-op chemotherapy. Other variants, lobular, medullary, mucinous, have slightly better prognosis and are treated the same way as the standard infiltrating ductal. Lobular has higher incidence of bilaterality, but not high enough to justify bilateral mastectomy. Ductal carcinoma in situ cannot metastasize, thus no axillary sampling is needed, but has very high incidence of recurrence if only local excision is done. Total simple mastectomy is recommended for multicentric lesions throughout the breast because of the possibility of missing an invasive focus in multicentric disease. Many practitioners add a sentinel node biopsy in those. Lumpectomy followed by radiation is used if the lesion or lesions is confined to 1/4 of the breast. Inoperable cancer of the breast is treated with chemotherapy, may also add radiation, and sometimes it is rendered operable. Inoperability is based on local extent, not metastases. Adjuvant systemic therapy should follow surgery in virtually all patients, particularly if axillary nodes are positive. Chemotherapy is used in most cases, and hormonal therapy is added if the tumor is receptor positive. Premenopausal women receive tamoxifen, and postmenopausal women receive anastrozole. Frail, old women with tumors that are not too aggressive may be offered hormonal therapy alone. Women who are positive for HER2 receptors should be given trastuzumab Herceptin along with chemotherapy. It should not be given alone. Trastuzumab is currently the most powerful drug we have for systemic breast cancer. Persistent headache or back pain with areas of localized tenderness in women who recently had breast cancer suggests metastasis. MRIs are diagnostic. Brain metastases can be radiated or resected. The vertebral pedicles are the favorite location in the spine. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atif Ahmed. Best wishes, Dr.